Welcome all. This is the ASH Smoke-Free NHS Network event, and we're here today to discuss cytisine and Varenicline. And it's great that so many people have joined. I think I was told that there's going to be probably 300 or 400 people joining all together from across the NHS and local government. So anyway, welcome everybody. And we're going to have an overview today on Varenicline and cytisine, which are two new medications that have become available in the past 12 months in the UK to treat tobacco dependency. And it's really exciting because before that, we've really only had a couple of medications that we can use in the, well, all types of medications that are both nicotine related in the form of dual NRT or e-cigarettes. But now we can extend our armamentarium, which is great news. A couple of housekeeping points. Could everybody please keep on mute? But it would be great to see people's faces. So if you want to keep your cameras on, that would be great. This webinar is going to be recorded so that people who couldn't attend can look at it, and it'll be one of the resources. It'll be posted on the ASH website, and also the link, I think, circulated, and there'll be some slides available and other resources. So this meeting will be recorded. If anybody has any technical issues, which can occasionally occur, please put them in the meeting chat or email admin@smokefreeaction.org.uk. Now, I just wanted to give you an idea of the agenda today. So I'm going to just introduce the session in a second with a couple of slides, and then we've got some fabulous speakers lined up for you. The first is my colleague Matt from Manchester, Matt Evison, and he's going to describe how he and the team in Manchester have rolled out cytisine and Varenicline and some of the enablers and barriers locally that they have used. Then we have Kieran Reynolds, who is an advanced specialist pharmacist from the medicine governance team at Specialist Pharmacy within NHS England, and he's going to talk about the Varenicline PGD. Then we have my colleague Joanna Feeney, who is a stop smoking systems strategic manager at Fresh and Balance up in the North East. And has developed a regional PGD pharmacy supply service for both Varenicline and cytisine in the community. And I know that many of you are from local government services, and that's going to be really important. And just to be clear, that this webinar is really for colleagues both in the NHS and local government, but at times I know it might feel that it's more NHS focused. And then finally, last but not least, we've got Sophia Papadakis and Louise Ross, who will be describing some of the training and other resources available through the National Centre for Smoking Cessation Training. So it's going to be a fully packed webinar. It's an hour and a half. Everybody's going to have about 10 or 15 minutes to talk, but there will be opportunities for questions at the end. If you have questions along the way, please put them in the chat, and we'll also try and answer them as we go on. So I'm going to get started now. So Claire, are you able to pop my slides up for me, please? So I wanted to start by saying that, this is a life-saving opportunity. These two medicines that work in the same way, by the way, and we'll get onto that in a second, are literally life-saving. They are really effective. They are the two of the most effective medicines we have to treat tobacco dependency, and they are on a par with e-cigarettes for helping people quit smoking altogether. My estimate was that at the moment there are about 200,000 people per year coming through local government stop smoking services, and we identify about 200,000 people who are inpatients or in maternity services coming through NHS hospitals at the moment through the inpatient pathway. So there's a combination of about 400,000 people that are touching our services in NHS and local government, all of whom could potentially be provided these life-saving medicines and help somebody quit smoking permanently, which of course then reduces the risk of comorbidities and exacerbations of a variety of diseases. For those of you who aren't aware, Varenicline has been in NICE guidance since it was launched back in 2007. It's it had a NICE technical appraisal, and it was recommended that all NHS providers have this on formulary and have this on stock. That was back in 2007. Unfortunately, it went out of use. The company took it off the market in 2021 due to some impurities found in the preparations, but it was relaunched this year in the UK by a company called Teva Pharmaceuticals. So it is now available again, and many of you will be familiar with it. Cytisine, which works in a very similar manner to Varenicline, has been available in Europe for some 50 years now. It was launched in the UK in January of 2024 and is also very effective and well proven in clinical trials. Both of these medicines are part of our armamentarium for people with tobacco dependency. And it's probably also good to say, again, I'm not sure how much everybody on the call knows how these medicines work, but unlike lots of our other NRT products, these are tablet pharmacotherapies. They do not contain nicotine, and we know that a lot of our patients and people using our services, there's a large proportion of them who don't necessarily want to use nicotine products, and so Varenicline and cytisine offer them another choice. Some of you may be familiar with a new publication that came out last year from the British Thoracic Society on the clinical management of inpatients for tobacco dependency, and both Varenicline and cytisine were included in that under step 6, discuss and offer prescribed nicotine analog medications. So both NICE have recommended Varenicline and are likely to recommend cytisine when they update their publication in February of next year. So they're NICE recommended, BTS recommended, and we should be using these medicines in clinical practice. Next medication, please. Next slide, please, Ian. So we recognise that on this call today, there'll be people who are only based in local government services. There are going to be people who are based in NHS services, be they hospitals. There might be some primary care colleagues as well. We recognise the funding for both of these services comes from different sources, but however, both of these services often overlap. So in the NHS, when somebody's admitted as an inpatient, or for example, being seen in the community through maternity services or community mental health services, a lot of these patients start in the NHS, but then there's a transfer of care to our local government stop smoking services. So somebody might get started on Varenicline or cytisine in the hospital, but then it needs to be continued when they continue their quit journey in local government. And in between these services, lots of local government services have their own stop smoking advisors, but we also know there's a pathway that includes community pharmacists. We also know that some hospitals do the whole treatment package for the whole 12 weeks via their hospital. And of course, more recently, we've got lots of smoke-free digital apps that also could provide these medications. So there are lots of providers of stop smoking therapies, but the two main ones at the moment, of course, are in the NHS and local government. And it's collectively that we need to think about how we provide for Varenicline and cytisine to the patients using these pathways. Next slide, please. Locally in the Midlands, we started a pilot with the 11 ICBs in the Midlands to get going with cytisine and Varenicline. About a year ago, we started with cytisine, and then more recently, we started with Varenicline once it became available. What we worked out and what everybody described on the calls was that these are the general steps that everybody has to take. So on this call today, some of you won't have started your journey yet to providing cytisine or Varenicline. And I would say these are the standard steps, and I'd like my colleagues who are speaking later to think about this as well and see if there's anything else to add. But I would say the very first step is getting it on your local formulary. For me, that means my hospital, but there's also a primary care formulary that these drugs need to get onto, so that local government providers can also work with GPs to provide the drugs. If you're a hospital-based service, you also then need your hospital pharmacy to procure the drugs, and then develop a way of being able to prescribe them. And lots of hospitals now have e-prescribing, so that e-prescribing system needs to be enabled to allow this to happen. And I suppose in GP practices who may then prescribe these drugs in the community for patients, they need to be able to prescribe them using their electronic systems. There needs to be a standard operating procedure and a patient group directive in the hospitals or in the community. Kieran's going to be talking about the standardized patient group directive that's now available, that all of you can use and make your own. There are lots of standard operating procedures. I have one in my hospital. I'm sure Matt has his in Manchester. And I would say, don't try and reinvent the wheel. There are lots of resources out there, and I'm not sure that Ash and the team could provide some examples that then you can adopt. And that's really to describe how you're going to use these drugs, who's going to do the prescribing, what to do, and to expect with side effects, etc., and how they might be managed. So an SOP and a PGD are a step that you'll need to take. There are patient information leaflets that we've developed and provided to our patients for both cytisine and Varenicline. And a lot of these go through patient groups to make sure the language is suitable. And again, these have already been developed by lots of places, certainly in the Midlands, in the hospitals that have been using it. The next step is, of course, training. So for the TDAs in hospitals or stop smoking practitioners in the community, to become familiar with both cytisine and Varenicline, how they're used, how they're given, what the side effects may be, etc. And the NCSCT team will be talking about that. And then for those people who are in hospital and discharged, there'll be provision for ongoing supply at the time of discharge from hospital or outpatients, and how is it that patients are going to get their full course of treatment. For cytisine, it's just 25 days, and for Varenicline, it's for up to 12 weeks. And then, of course, for community providers of stop smoking services, the question will be, how do you get supplies to patients? How do you continue supplies? And we know that people switch from, for example, NRT to maybe cytisine, to then maybe an e-cigarette, to then maybe Varenicline. And how do we make sure that our pathways enable patients to receive these nice recommended treatments? So these are the steps that our 11 ICBs in the Midlands have taken, and for many of them we've started prescribing cytisine in at least 4 ICBs. Another 2 or 3 are coming on board in the next couple of months, and all of our providers are planning to introduce Varenicline. Pretty much all of them in the Midlands have, I think, got them onto their local formularies and have started the rest of these steps. So I'm going to ask Claire to take down the slides, and then I wanted to introduce my colleague, Matt Evison, who's a professor of respiratory medicine in Manchester, and is going to take us through the Manchester experience with Varenicline and cytisine. So over to you, Matt.
Brilliant, thanks, Sanjay. So am I slide sharing just before I start talking?
Yeah, they are.
Yeah,
yes.
So welcome everyone. It's amazing to see the numbers here for today's session. I guess this is the interest in these medications and what an important moment this is for us in the tobacco control world, having these new medications back and new medications. We've got such an opportunity in front of us to embed these. So I'm going to talk about the Greater Manchester experience. It's very, very similar to how Sanjay just laid out the steps, which is good to hear, and maybe just add a few points around that. So I'm going to talk a bit about how we've approached this as a region, and I think that's it's been really beneficial to start this process with a regional protocol for the management of tobacco dependency from a medical perspective. This has been through, so for our ICB for Greater Manchester, NHS Greater Manchester, we have the GMMG, Greater Manchester Medicines Management Group. And that's the vehicle through which we can approve new medications, consider optimal prescribing practices at an ICB level. And we wrote this protocol quite a few years ago, which has been really beneficial. It's been helped us have a position on nicotine vapes. It's enabled us to have a standardized NRT prescribing protocol. It's been a good protocol for helping the work we do in tobacco. And then when these medications are available again, it's been the natural or the obvious place to update that protocol first, have it approved, and it then makes all the steps after that a little bit easier in terms of formulary applications and formulary approvals. So once a medication is approved by GMMG, it then should be an open door at every local trust because that's been approved at a local level. I'll touch, just as Sanjay talked about, on electronic prescribing, the education part, and a few of the things we've done locally and progress so far. I seem to be showing this slide everywhere at the moment, just because I think it's such a brilliant bit of work, because Cochrane is such a trusted, it's such a methodologically robust process. And they've told us and demonstrated to us, the team that put this together, that these are the most effective treatments for tobacco dependency: nicotine vapes, varenicline, and cytisine. So this, for me, just sets the standard of care. For a person that smokes at any touch point with the healthcare system, their right and our responsibility is to provide access and the opportunity to access these most effective interventions. And varenicline and cytisine are a key part of that. And that is now our standard of care. It's all, how can we achieve that standard of care? And we have to keep working until we are at that point where every person that smokes gets that opportunity. And that now is the moment, because they're now both available. We've got misinformation to combat about nicotine vapes and make sure everybody gets access to them. And I think it's just worth reflecting back, whilst cytisine is new, and that's really exciting, we had varenicline for a long time, and we had all the evidence, even at those moments, and we know the uptake of it wasn't where it should have been. So this is some of the national audit data from hospital-based tobacco treatment, and over every trust in England, over an audit period, there were just 3 people prescribed varenicline. This was across times where varenicline was available. So it's I think we've got to use this as a new moment, and even consider it a new medication, and make sure we get this embedded at scale. As Sanjay mentioned, I think the BTS framework is really good for inpatients. We hope it's a simple framework that if everybody implemented it, it's simple steps to make sure every patient gets optimal care. And just to highlight, so nicotine analogs, varenicline and cytisine, are a specific building block in this framework. The other important bit is it just acknowledges how good they work in combination, and the inpatient settings are a really important part of that, because NRT is our cornerstone of managing and mitigating nicotine withdrawal. Very readily available, rapid onset, and we can start that immediately as somebody hits the hospital entrances and A&E and wards to mitigate that withdrawal. Varenicline and cytisine, they take time to reach their maximal effect. So as an outpatient, that person may continue to smoke and reduce their smoking as the effectiveness kicks in, and then stopping. In the inpatient setting, in a smoke-free hospital, that can't happen. So NRT is the perfect substitute in that early part of the admission, whilst additional nicotine is needed, whilst these drugs take maximal effect. Was very much the thought behind the building blocks in the BTS framework, that it builds on each other, not one or the other. So these new treatments are really good for the inpatient setting, and they combine nicely with our existing practices. And I just wanted to highlight this systematic review that I think really did bring home some of that in terms of the value of combination therapies. We know varenicline works really well. When it's combined with NRT, it's even better. So From our GM experience, I mentioned that we first developed this protocol. So it was 2019, so it's 5 years ago we first wrote this, and it was very much centered around NRT and having a standardized protocol for both inpatients, outpatients, in stop smoking services. And it was been a really good document for us. It's helped us in that work at a regional level. But then also became the key point when cytisine became available. So January 2024, we'd updated this with the introduction of cytisine and to align with the BTS statement. And very soon after, we got the brilliant news that Varenicline was coming back. And again, an update added because we'd acknowledged that it wasn't available in previous versions, and we could then take that away again. And there's nothing new in this protocol. It's just us and Greater Manchester putting it together and acknowledging what are effective treatments and trying to support implementation. So it's all stuff that's already there. And the way this protocol was written is that we identified very effective treatments, we identified effective treatments, and identified less effective treatments. So Varenicline, cytisine, nicotine vapes are very effective. Combination NRT is effective. We know that single agent NRT or bupropion is probably less effective. And that it's not saying this is where we start with this first choice treatment. We know a lot of that is driven by patient choice, but it's acknowledging that we do have some of those most effective treatments. And so this just lays out some evidence base and some of the prescribing around it. Cytisine, again, we've just summarized the evidence base, and by doing this it really helps our formulary application, because every formulary application has to have a summary of the evidence base, and we'd already been through this as a group and agreed it all, written it into our protocol, so it was very easy to reference and just present the prescribing regime. So after that had been updated and accepted, as I say, it made the formulary application much easier. And this is just a snapshot from that formulary. And there is a link. So the NCSCT very kindly put this onto their website. So if anyone is at the start of that journey and is doing formulary applications, then hopefully it makes that work a lot easier, because it's there, just copy and paste and use the summary of evidence and anything in there that is helpful. I think I just picked out a couple of things because these were really central to our discussions as a regional medicines management committee, that you have to think about commissioning implications. That was a big question asked towards us. And cytisine at a 25-day course is £115. Looking at our data, it's approximately about 300 per treatment course for combination NRT. We supply vaping devices, as do many stop smoking services and NHS services, which about on average will be £150 for device and e-liquids, and Varenicline's around £180. So that 25-day course does mean it's a single prescription, so there isn't a need for repeat face-to-face consultations and potentially some efficiency savings there. So really the conclusion of that discussion is that it represents a cost saving for the GM system, and to have our medicines management group say that was very, very helpful. It really did make the rest of the conversations after that much easier. And these are all they're publicly available documents. So like many other organisations, they publish the minutes of their board meetings. And so this is taken from early 2024 and summarises the conversation that happened in that GMG board meeting, by which they went through that evidence base, acknowledged its effectiveness, and acknowledged to approve it as a first line product in line with our updated guidance. And it went through an open consultation process as well, finally before that approval. And then when you look at the minutes from the board meeting afterwards, both the protocol and cytisine have been approved in GM. So as I say, I think that the timeline about using that protocol update, then the formula application, was a really helpful one. And so cytisine was approved in March, and it was then, for me, it's then over to my trust and how we then get that process done, and the approvals through the local medicines management group. Very straightforward once it's had the regional stamp, and that's been stocked since the middle of the year, and we've been prescribing it since then. And a very similar story for Varenicline. When you go through the minutes and the notes of the GMMG in terms of Varenicline, it was a much speedier process because this is a returning medication rather than a new one. But the conclusion was the same, that there were no commissioning implications for this. And since October, we've had it stocked and available. So at MFT, at my trust, so cytisine is available for inpatients, for outpatients. We use it in our lung health check program. In inpatients, we use it alongside NRT at the beginning of the journey, and we provide the full 25-day course. And that's very simple. For 25 days and 100 tablets, that just makes complete sense to provide all of that. Varenicline was a more in-depth discussion where ultimately we have, after much discussion and advocating, we provide the full 12 weeks of the Varenicline prescription as well as an initiation pack and the rest of the completion. That's really the two key discussion points around that. Was if we created inequity versus cytisine, so one therapy where you get an entire course and another where you don't, we are potentially creating inequity. And equally, the availability and our assurance that if we started a course in hospital, that could be completed with ongoing prescriptions beyond discharge or via alternative methods. But didn't have that full assurance. I think things are still coming up through primary care in terms of being available and on prescription. It just couldn't really take the risk that we start a medication and it doesn't continue. So the full 12 weeks is being provided. And we've found since that both of them went live, there is an immediate engagement and uptake. So many patients are coming back for Champix. They will call it and say, I've had a course before and I wanted it again, or have heard about new medications and are seeking it out. So from the very first day, we've been prescribing it. I think last Friday was our busiest day of prescribing 6 courses in a morning's clinic from our tobacco dependency team. And so the logistics of that is just a quick screenshot of our electronic patient record. So we have made the transition to Epic, which has many painful parts to it, but there are really good parts of having a fully electronic patient record. And we have a cytisine and Varenicline prescribing group. So for our tobacco dependency advisors who are not nurse prescribers, and they see a patient and they've talked to them about Varenicline and they want to start that patient on it. In the ward setting, they have that, and they may be able to go to the ward doctors. In an outpatient clinic that they run, they need to come to us. And so we have a messaging group where if there's somebody identified, we will then prescribe it for them. And those the prescribing programs that Sanjay mentioned, these are all now built into Epic and what we call Hive. So the initiation pack is built in. We just have to fill in that for the first 14 days, followed by the maintenance pack, the 1 milligram BD then for 70 days beyond that. And cytisine is just the same. Its original name is cytisinicline. And so when we first launched this, and I went around everywhere saying we've got cytisine, I had 100 messages back saying I've tried typing it in, I can't find it. So so yeah, I have to just be aware that there's a longer name for searching by it. But that is all now built in. It brought some questions up really quite quickly in that, well, we've got 2 of them now, and how do you decide between the 2? I think generally what we've found over these last few months is it's so patient choice driven on previous experiences, their wishes of having a 12-week longer course versus a shorter 25-day course. We do talk about cytisine having reduced adverse effects versus Varenicline. I think cytisine is quite a difficult regime in the inpatient setting, from the 6 tablets a day to then up to 5 tablets a day to up to 4. Without that very specific this time, is it a PRN medication? Is it a regularly provided medication? In some ways, Varenicline's a little bit more straightforward than that. Cytisine has some cautions, which makes Varenicline a more obvious choice. We worked so hard to get over this mental health illness concern with Varenicline, and we quote the Eagles trial so much. for patients to get into that Eagles trial, they had to be stable for 3 months. There'd been no adjustments to their medications. That was one of the trial entry criteria, and we use that in terms of in the same way for prescribing varenicline. So we've got absolutely no concerns with someone with stable mental health illness. Even with unstable, it doesn't mean we can't use it, but really for our team, they come and get some advice from us. And it might be with cytisine that doesn't have those cautions within the prescribing guidance, that may be a better choice. And the only other thing I'd just add is that in a cancer pathway, which is one of the areas I work in, actually this rapid reduction in dependency I think can be quite useful with cytisine, and there's treatment coming on the horizon. So just finishing up with the education for this is so important. We've got to rapidly increase prescribing confidence quickly, and there are loads of resources. You'll hear about loads of them today. We've published a few on the Greater Manchester Make Smoking History website. They are seminars on vaping, on cytisine, on varenicline. It's both slides and a voiceover to it, and they are publicly available as other guidances. We've also just launched a Smokefree NHS toolkit for hospitals, and within that it talks about the importance of smoke-free steering groups. We've listed within that one of those responsibilities of being the implementation of cytisine and varenicline. We've put into that toolkit that's shared across all of our hospitals currently and is undergoing an implementation phase what a tobacco dependency clinical lead is, because we need these clinical leaders to drive these things in hospitals, in any healthcare setting. And again, one of those responsibilities being ensuring equitable access to these highly effective treatments, and through PGDs, through everything else. And that smoke-free policies should include cytisine, varenicline, how we're going to ensure access to these things. Our PGDs are all now currently been submitted. I know we've got a national varenicline one, there's a national cytisine one coming. Again, we've shared the ones that we've submitted previously if they are helpful to anyone. The only reflection I've got from the PGD is that we were really challenged about using it in an inpatient setting, a PGD in an inpatient setting, because there's prescribers nearby, and a PGD is when there's that availability isn't there. And we really had to fight quite hard for this. So if anyone else comes up against that barrier, we actually had to write, the text in red comes directly from our PGD. We had to write in the importance that if we don't have that PGD, we risk that that medication isn't prescribed, or that person on the ward doesn't have the prescribing confidence, or it's delayed and it doesn't happen, and we will miss that opportunity. So just be wary of that. So in conclusion, I think it's such an important moment right now. We've got these medications that work so well, and we need clinical leaders. We need that at regional level, at trust level, to drive this forward and drive the framework by which they can be prescribed and accessed, and then rapidly increase our prescribing confidence across the healthcare system as one part of a hospital-wide approach to tobacco dependency. And this is now our new standard of care. Every person that smokes should have the opportunity to access cytisine and varenicline as part of their treatment. And I will stop sharing there.
Brilliant, man. That's great. Just as ever, fantastic work. And I think you've been seeing all the claps that have been coming up on the screen. So clearly it's very well received, and some brilliant resources that you've pointed people to.